So I'd love to just take the pleasure of introducing Professor Pallav Shah. Pallav has been working with us for a number of years, also working very closely with Patrick Byrne at the back, Patch, lovingly referred to by us at Creo, by the team at the Royal Brompton and several pulmonology sites around Europe, and also by the team at Intuitive Surgical, who have been working alongside Pallav and us on the project with Microblade Flex. Just to give you a flavour of the people in the organisation, just going slightly off script, Patrick was a PhD student in North Wales under the tutelage of Chris Hancock, who sadly can't be here today, our co-founder, and he's been through his PhD and engineered and delivered the programme alongside Pallav and been to many of Pallav's cases, and has also been running the programme with Intuitive. So we owe a real gratitude. I'm grateful that Patch is here. More important to you guys is when you get to the end, feel free to barrage Patrick with any questions that you've got about how we got here and how we work with Pallav. But as I'd like to do, just hand over to Pallav and talk about some of the terrific results that he's had, and pleasure to have you. Thank you.
Great. Thank you very much for the generous introduction. Basically, it's a privilege to be up here today to share with you some of the work we've been doing. In fact, you're probably the first people to see this data. It's not peer-reviewed and it's not public knowledge yet. So I'll just try and take you through this journey. Basically, what we're hoping to do is really transform lung cancer care. Now, just to put this into perspective, this is not a single tube. There are about 100,000 branches in the lung. So as lung cancers become more and more peripheral, this is quite a challenge to target anywhere in the lung in a very specific manner. So there are a few more issues that we face rather than just delivering an energy. Now, to put it into context, this is the data. And if you look at lung cancer survival, so approximately in the UK, we have something like 46 to 50,000 lung cancers each year. And unfortunately, we get about 40,000 deaths each year. So what does that translate to? The problem is that most of the patients, up until the last few years, used to present quite late in the natural history of lung cancer. If you put this on a global scale, there are about 2 million cases of lung cancer each year, and probably about 1.5 to 1.6 million deaths each year. So it's a real challenge. But what we've shown probably most successful in the UK is that lung cancer screening works, and if we find these spots early, we can make a huge difference. And this kind of illustrates this. And if you find a tumor that's less than 10 millimeters in size and give that patient the best treatment, the cure rate is 92%. But you can see it changes quite dramatically. If it drops to 21 centimeters in size, the cure rate's now 83%. If it's 30 millimeters in size, it's 77%. And if you've got any lymph node spread, it drops to about 50%. So finding it early is crucial, but if you can find it early but can't do anything about it, then again, what's the point? So really, this is really what we're trying to do, and this is the latest data from the US SEER database, and again, just reinforces that. It subdivides this into much more detail in terms of size, but the clear message is the earlier we find these lung tumors, the more we're able to do for them. So you've all seen this setup so far, ultra high frequency microwave energy, and in this case we're using it slightly differently to destroy tumors. So we're not doing any dissections, we're basically placing this in the center of a tumor and then ablating it. And here's one of our early patients. This patient actually had chemoradiotherapy for lung cancer. They were under follow-up, and if you look at the area up here, you can see a little spot growing up. So this is within the field of the chemoradiotherapy. So this patient couldn't have any more radiotherapy, and normally they would just have systemic chemotherapy and it'd be palliative. But what we did in this patient, and you can see again, the PET scan just highlights that it's very active and therefore likely to be recurrence. We didn't know it was recurrence for sure, but this is the procedure we do. So essentially, we map up the CT scan from the patient, we match it to the patient. The way we do that is by driving the robotic catheter into the various aspects of the lung. And my left hand essentially moves the robotic catheter forward, my right hand can move it 360 degrees. So literally I can go anywhere in the lung with this. And we're going to about 70% of the depth of the lung in each area to synchronize the CT that we've got before the procedure with the patient. And once you map out all those areas, you can see the blue light coming on, so you map that area of the lung, and once you've mapped all the areas of the lung, you've essentially synchronized that imaging. And then becomes the navigation bit. So once you've synchronized it, it's a little bit like GPS in our car, and what we do is we follow the blue line. So we now stop using our brain, we just follow the blue line, and makes life so much easier when you're trying to find 300,000 branches. So basically, it's cut down the procedure time quite dramatically. So something that would take me 30, 45 minutes, now it takes me a minute and a half to do. So basically, it takes me 1.5 minutes to get to the lesion. And like every good video game, you get a nice target showing up when you're in the right spot. And when you've got your target in line, what we tend to do is we can either put ultrasound or various tools in to see if we're in the right spot, or even better, we've got a CT scanner in our bronch suite, and we perform a CT scan, and in 5 seconds I have an image which tells me where I am. So we've segmented this nodule there, and we can see the robotic catheter, and when you look at it in 3 dimensions, you can see I'm at the exact correct spot in line with the spot. And then once I'm there, I can then throw in different tools. I can biopsy this lesion. That's a needle going into that area, so we're making kind of pilot hole into it. Then I'm going to put an ultrasound probe into it. So this is, this is a cryo probe. So this allows me to take a biopsy. And this is an ultrasound probe that tells me I'm dead center in this lesion. So I've got central strike. And then the next step is for me to then double check very quickly while we're still doing the procedure. Under the microscope, you can see there's clearly cancer cells there. So there's no questions for me. In that same procedure, I'm going to destroy this tumor. So we then put in a microwave ablation catheter, the one you'll see with Patrick on the desk. Here's the microwave ablation catheter in the center of this lesion, and then we withdraw the robotic catheter away, so the microwave catheter is exposed so that it can deliver the energy without any interference. And so this is the microwave catheter just being gradually withdrawn. And then once I'm in the optimal position, we also then can check with that CT scan, we can segment the lesion. We can put a tumor margin around it. So here's us segmenting the lesion. We put a tumor margin in it. And then we can also map the ablation zone. And if it's all green, we know that I'm going to adequately ablate this tumor. If it wasn't optimal, I could reposition, or I could take the decision to do one ablation there and then in an area where I think the ablation wasn't performed. And this ablation process takes a whole of 3 minutes. So, and not only the advantage of 3 minutes compared to all other technologies which take a minimum of 10 minutes is I can then do it in a breath hold. If you do it in a breath hold, you get very precise ablation, exactly like you want it. Plus, the catheter we use is the high frequency one, and with this combination, what we're getting is almost a surgical precision, 28 millimeters every time in a spherical view, as if you've just cut out that lesion. And this is pretty consistent. So this is 24 hours after the procedure. You can see you've ablated the lesion, and then you can follow it, and you can see this is day 1, this is 3 months, it starts to shrink, 6 months, it's even smaller. And if I show you other lesions, just to get your eye in, you can see when you first treat the lesion, it's actually going to get bigger, because you've heated that area up, you're going to scar the adjacent lung, and then over time, you can see that it's shrinking. And in all of these, you can see all of them shrinking. And this is the kind of pattern we get. Now, this is, obviously I don't expect you to read this, but this is just to highlight to you that we've very systematically gone through, so far, 35 patients in this particular trial. This is a trial where we treat these patients. Most of them are either not fit for surgery, so they've got emphysema, cardiac disease, multiple comorbidities that makes them unsafe for surgical resection, or alternatively, there were a few patients that actually vehemently refused surgery but did accept this modality, and then there were a few patients who had metastatic disease from other sites. And then the plan is just to follow them over time and see what happens. This table shows you quality of life. So one of the most striking things is that if you do surgery, all the patients have a blip in terms of their quality of life deteriorates and then improves over time. If you do radiotherapy, it's the same scenario. They get esophagitis, they get pneumonitis, they can get rib fractures. Transthoracic, so putting a needle in from outside with microwave energy, has been around for almost 10 years. Those patients stay in hospital for about a week. They have pain. They're on a patient-administered anesthesia, so they're giving themselves shots of morphine literally every 4 hours. In contrast, these patients go home. We keep them in overnight at the moment just as a precaution, but technically none of them have had a flare-up or any significant adverse event, and I could send them home 2 hours after their procedure. Sorry. So this is just to try and put into context some of the adverse events of transthoracic microwave ablation. So when you put a needle in from outside, you'll see death rate of around 2%, pneumothorax, so a punctured lung, in 33% of patients, 34% of patients, fluid, almost 10%, hemorrhage, 2 to 34%, fistula, which is a hole between the lung and the lining of the lung, again, quite a significant morbidity, 4%. Air embolism. So if you get an air embolism, that's air tracking in from the vasculature, can travel to your brain and cause a stroke. It can go to your heart and cause cardiac arrest. That occurs in about 1%. And then infection and post-ablation syndrome. Now, this is actually based on well over 3,000 patients treated. So we know that their data is pretty robust. We'd like to get there, but in our series of patients so far, the order of magnitude of these events, you can see, is completely negligible. We had 3 pneumothoraces. 2 were due to the biopsy that I did before I ablated. 1 was probably related to the ablation, but again, that translates to a 3% compared to 33%. Local recurrence has happened in about 4 out of these 30 patients, but like I said, we can retreat those if appropriate. But actually, most of these patients, when we've dug down to them, actually had fine metastatic disease that we couldn't see at the time of treatment. So they had small nodules in multiple areas. So some of them had nodules gone to the liver, some of them had brain metastases and lung metastases. So probably they were not suitable for treatment, but at that stage we didn't know that. There was 1 death in the study, which I think, I may be biased, I don't think it was related to the procedure. It was essentially a patient with emphysema and COPD. He went to his local hospital about 10 days after the procedure with the exacerbation of COPD. He had carbon dioxide retention. So if he had come to our institution, we would have put him on non-invasive ventilation, tided him over that acute stage, and he would have been fine. He saw a nihilistic physician who basically put him on a morphine pump and allowed him to die and gave him no intervention at all. So I'm kind of upset about that, but I think on balance, I'm not sure that it was related to the procedure. But obviously, you know, we're transparent, so we report everything. Now, so one of the unique things we've done in this study is half the patients had a biopsy and ablation in the same sitting, something that's actually almost thought of in the medical world as a fairy tale. Normally, you'd biopsy it, know what you're dealing with, and then treat it. But what we've shown is whichever strategy we use, there's no difference in the outcomes. But in terms of patient care, this means a lot. Because if you look at the lung cancer pathway, for example, an average patient in the UK, it takes them about 3 weeks to go from the GP to the specialist, then to have scans, then to have diagnosis. Guess what the average time after their journey started do they get treatment? Any ideas in this room? About 120 days. Now, we can do this. If we use this kind of pathway on a larger scale, you could treat these patients, you can diagnose them and treat them and even stage them in the same sitting. So you can, and the procedure itself, like I showed you, takes about 30 to 35 minutes. So you just imagine, compared to surgery, how much more we can transform this. But let's just slow down a bit. At the moment, we need to build the evidence. The evidence so far we've conducted is in patients who are not fit for surgery. Surgery is still the gold standard. It will remain the gold standard until we can accumulate a lot more evidence. But this shows that this is a modality that has several serious leverage. So this is a 1-year survival curve. You've got radiotherapy or SBRT in red. You've got surgery in blue. We were doing quite well until one patient got a recurrence. So you can see that disease-free survival or recurrence-free survival at 12 months so far is following the lines of what our traditional modalities are. We just need to prove this at a large scale. But not only that, we are at the moment doing a study where we treat the patients, but then a month later they have surgery. That means we can actually genuinely evaluate, are we actually treating the lesion in the same way we think? So are we treating every single lesion 28 millimeters every time? I think we are, but we need to prove it. So there are a number of studies we need to do before this becomes mainstream, but you can see that if something like this works, it's going to completely transform care from what we're doing at the moment. And maybe other dilemma in medicine is that we find these nodules, but not all of them are cancers. So the normal strategy is let's just do another CT scan in 3 months. We'll do another scan in 6 months. We'll do another scan in 12 months. But now what we can do is we can actually completely change that paradigm and make it so that we're doing a diagnosis much earlier. And in those with early diagnosis, you could have this option, or you could have conventional surgery, whereas otherwise, in more advanced disease, you really can't have this kind of curative approach.